1 year ago, amid high hopes, the Affordable Care Act was rolled out and immediately crashed. Even its supporters admit that the process to enroll people in health insurance exchanges was originally a disaster. Still, by the time enrollment closed for the first year, more than 7 million people had signed up for Obamacare. Now, open enrollment is here for year 2. And depending on who you believe, between 9 and 13 million people may enroll this time around. But some experts say signing people up has never been the problem with Obamacare. It's getting access to care once you're signed up.
The intent of the law was to really provide medical care for patients. And what's happened is patients are able to get an insurance card, but then they're finding it very difficult to get appropriate medical care.
That's Dr. Andrew Kleinman, president of the Medical Society of the State of New York.
The whole purpose of having some sort of a national health care policy is to provide better care for patients and more accessible care for patients. And unfortunately, because of the way the exchange is running, the accessibility of health care for a lot of middle-income patients is actually becoming less, not greater. So it's actually having the reverse effect of what it was supposed to be.
Kleinman says the private insurance companies that run Obamacare plans have drastically pared down the list of doctors people can choose from. That's somewhat euphemistically called a narrow network.
The exchange is kind of like narrower groups of physicians, narrower networks for lower price plans because they feel that they can control expenses a little bit better. Unfortunately, one of the ways they're controlling expenses is they're making it harder for patients to get appointments with physicians, therefore delaying care more. And the insurance plans that they're writing for are ones that are so meager, it's very difficult for a lot of the people in the exchange to find appropriate medical care, to find a physician. I know President Obama at one point said, if you like your doctor, you can keep him. Well, for the exchange plan patients, that's certainly not true.
What's more, even when an insurer wants a doctor in their Obamacare network, the doctor may not be interested.
There's a growing expectation that doctors are not going to be willing, many doctors are not going to be willing to take some of the Affordable Care Act patients because the Affordable Care Act, in many cases, pays so little.
That's Merrill Matthews, resident scholar at the Institute for Policy Innovation in Dallas.
Right now, there are concerns that they're paying roughly around where Medicaid pays, and Medicaid is the federal state health insurance program for the poor. That tends to pay in the neighborhood of 50 cents to 60 cents on the dollar of what insurance would pay. Medicare tends to pay a little more. Medicare is the federal health insurance program for seniors. That tends to pay in the neighborhood of 80 cents on the dollar of what insurance would pay. So you can see that if you're a doctor and you're getting roughly half to maybe 60 cents on the dollar of what standard insurance would pay, it makes it difficult for you to have an awful lot of those patients in your practice.
If a physician does participate in the exchange, and a lot of the patients he takes care of are in the exchange plans, the reimbursement is so low that it's very likely that it's below his cost of doing business. So therefore, on each patient he's seeing, he's actually losing money. That's not really compatible with staying in business for very long.
In fact, at least for the rest of this year, what many doctors are paid by Obamacare is much lower than even Medicaid.
Right now, especially for primary care, the Medicaid rates everywhere are higher than that because Medicaid is now reimbursing for the time being at Medicare rates. So yes, the exchange patients are actually being reimbursed at a lower rate very often than Medicaid patients.
For now, that makes insurance from an exchange the lowest tier of health insurance in the United States and the lowest tier of care.
I think this country has long had different tiers of care.
Dr. Paul Ginsberg is Norman Topping Chair in Medicine and Public Policy at the University of Southern California.
Medicaid beneficiaries, have less choice, less access than either Medicare or commercially insured patients. And, there are increasing anecdotes about physicians limiting the number of new Medicare patients they'll take. So this is just another tier.
Patients are beginning to find that being in an exchange is a lot like Medicaid. Nationally, only about 2/3 of doctors accept Medicaid patients. In some places, Matthews says it's a lot worse than that.
In Texas, and the Texas Medical Association does this survey every now and then, I think we're down to about a little over a third of the doctors in Texas are willing to take new Medicaid patients. If that's going to be the primary care doctors, it really becomes difficult to find a specialist. In fact, not long ago, I had a family physician who was also a state senator in Texas tell me that in years past, he used to be able, if he had a child come in who was on Medicaid and he felt like that child needed to go see a specialist, he would contact the specialist in Dallas and send the kid there. He said now he has to call that specialist and ask the specialist to do him a favor in order for the specialist to be willing to take the kid. So many doctors are simply not willing to take new Medicaid patients because it pays so little.
Obamacare exchanges in many states look similar. So few doctors have been recruited and so few are accepting insurance exchange patients that Kleinman says finding an in-network physician in some specialties is nearly impossible.
Almost everybody agrees that trying to find a private physician on Medicaid around here has been very difficult, and I think that's what's going to happen to exchange patients. I'm a plastic surgeon, and a lot of my practice used to be breast reconstruction. So I looked in one of the counties in the New York metropolitan area to see what plastic surgeons were available to do a breast reconstruction. And in that particular exchange plan, you had to go to a county that was at least an hour and a half drive away to find somebody in network. This is New York City. This is not a rural area where it's typical to have to drive that far to find a physician. But the network was so narrow, there was really nobody in the county where the insurance product was being sold who could take care of breast cancer. I find that shameful.
But Kleinman says many patients didn't know that their choice of network doctors was so meager when they signed up for a health exchange plan last year.
There were several plans who on their website were listing dozens of physicians as being in the plan, and they weren't in the plan. Some of these physicians had retired years ago, a number have moved out of state, and others just weren't in the plan. So there was one case in New York that was reported in the newspapers where there is a Yale Law School graduate who is suing one of the insurance companies because he lives in Manhattan and he signed up for one of the better plans, and he called all 30 internists who were listed in Manhattan on the plan, and not a single one was really available to see him as a patient. So he's suing the health plan for fraud, saying that they sold him insurance, but they're not really selling him the availability of care, which is what he thought he was buying.
Kleinman says there could be a way around that. People insured through exchanges now can't go out of network. If that were allowed, it could greatly increase access, and studies indicate it would only modestly increase the cost.
The difference in price that they found, depending on how much utilization there was out of network, was anywhere between 0.5% and 1.5% was all. This is not a very big area of cost of most of these plans. Most of the costs now are in things like hospitalizations or things like very expensive tests. So when you take a look at the component of the healthcare dollars that go to physicians, it's not a lot, and to pay a little bit more for that is not going to drive up costs substantially. And what you could do is you could make it so the insurance companies are required to offer an out-of-network option at a slightly higher rate to offset the cost.
However, the size of the network isn't the only surprise encountered by many first-time insurance buyers. There are also co-pays and deductibles. Kleinman says many buyers don't figure on those in their budget.
The plans that have the highest deductibles, the highest annual deductibles, are the bronze plans, which are the ones that are the most appealing to people with the lowest income, since those are the least expensive plans. And those plans have very large deductibles, and a lot of the patients who are attracted to those are patients who have never had traditional insurance. When they go for an office visit, they go for lab tests, they find out that all of that is within the deductible, so they're paying 100% of that out of pocket. So somebody who can barely afford to pay for a bronze plan finds that if they're going to go and they're going to get care, they're going to have a couple of $100 to a few $1,000 out of pocket for it, so they're not going to go and have necessary care.
One of the real objections among hospitals is the high deductible policies because they feel like they may get coverage from the insurance company for the expensive stuff, but the patient may not be able to afford the $5,000 or $6,000 that's the deductible up front. In fact, one of the major elements that is now emerging in the media, and this was completely predictable, in fact, it was predicted, is that some of these people with $5,000 or $6,000 deductibles who are lower income and never had insurance, they're going to a hospital or a clinic, and the clinic is saying, well, you're going to have to spend the $2,000, $3,000 for this test out of pocket before the insurance kicks in. And the patient says, I don't have that kind of money. So they end up going to free clinics or discounted clinics that are really there to treat the uninsured. But because they have a very high deductible now, they have to go to those various clinics and get discounted care or free care because they can't afford the cost of care underneath their deductible.
Sometimes that's put doctors and hospitals in the position of playing bill collector even more than usual. And Kleinman says there's one provision of the Affordable Care Act that makes it even worse.
The insurance companies are not allowed under the federal rules to cancel a patient, a subscriber, until he is 90 days in arrears on his bill. So what can happen is the patient can come into a doctor's office. The doctor's office calls the insurance company or goes online and finds out that this patient does have insurance. The physician then takes care of the patient. The patient hasn't paid the bills in a few months, and therefore it turns out that even though the insurance company told the physician that the patient was covered, indeed the patient turns out to not have been covered for that service. So that's becoming a major problem as well.
Many of the same problems will exist in the second year of the Affordable Care Act, but Ginsburg holds out hope that things won't be quite so bad and that consumers will be more well prepared.
I think there was a lot of activity before from buyers that were clueless about the narrow network, broad network. They just knew they wanted a lower premium plan. I think there is much more awareness of that now, and we'll have to see what happens as far as the choices they actually make.
You can find out more about all of our guests on our website, radiohealthjournal.net. I'm Reed Pence.